Hello, my name is Michael Mann. I'm a thoracic surgeon from the University of California at San Francisco and the director of our cardiothoracic translational research laboratory there. Today, we'll be talking about a new molecular prognostic technology that will actually provide new avenues, hopefully, to improve the care and maybe even improve the outcomes of our patients with early-stage non-squamous, non-small cell lung cancer. Of course, it's my duty to disclose at the outset of this talk that I do work for Life Technologies Corporation as a clinical consultant, and I have been one of the key people involved in the development of this technology. Now, I'd like to focus your attention this morning on several objectives for this talk. And perhaps the most important aspect of what we'll be discussing today is that not only do we have a real burning need for better prognostic information in improving the management of our early-stage non-small cell lung cancer patients, but there actually is a way to incorporate this new information into our management decisions in a very rational and well-supported way. So we'll be talking about that need, and we'll be talking about the immediate clinical utility of using that new prognostic differentiation of risk of death among stage 1 and stage 2 non-small cell lung cancer patients. Of course, in the course of this talk, we'll also give you some of the details of the development of a well-validated multi-gene prognostic assay that can confidently be used to help guide decisions for patients early after operation for non-small cell lung cancer. Now, the dilemma facing clinicians who are trying to manage patients with early-stage lung cancer really stems from some of the limits of the basic tools that we use every day in managing our practices. And of course, the vast majority of our decisions in management with regard to our non-small cell patients is based on the prognostic information from traditional TNM staging. And we were very pleased several years ago to be able to introduce into our practices the use of a new staging system based on more recent, more modern data culled from a large international database. But even after the introduction of this new 7th edition of AJCC staging for non-small cell lung cancer in 2009, we're still faced with a very large problem. Even patients with stage 1 and stage 2 disease represent a very heterogeneous mix of some patients who've been cured by surgery alone and therefore need no further intervention, with a large minority and in some cases majority of patients who, despite a stage 1 or stage 2 designation by the TNM system, must harbor undetectable, maybe even micro-metastatic disease even when they're undergoing their operation. And the reason we know that is because 30 to 45% of stage 1 patients and as many as 70%, 65 to 70% of patients with stage 2 disease are going to relapse even after so-called complete resection. So that metastatic disease is present in these early stage patients, if you will, maybe represent a problem of understaging, and yet we have no way to really better identify or discriminate among those stage 1 and stage 2 patients so that we can focus our attention at mollifying or modifying the risk that those patients face of early relapse and death within 5 years from the very same disease that we're hoping to cure in the operating room. So again, the poor outcomes that we're still suffering with in lung cancer, of course, are contributed from other factors, comorbidities. These are older patients. They are very often smokers and, of course, are encumbered with all of those other health-related problems. But the major culprit, perhaps as high as 90% of the deaths, early within 5 years after presumptive curative surgery for non-small cell lung cancer, are due to a recurrence of the disease, and that is most often involving metastatic disease at a remote location outside of the lung. So these patients are harboring disease that we just cannot detect based on our conventional methods of imaging and TNM staging devices. Now, I want to just remind you of a very stark and daunting fact, which is that stage 1 really means something very different for lung cancer patients compared to patients with other common solid tumors, such as breast and colon cancer. A stage 1 patient with those other tumors is facing a 90% or better chance of long-term survival with just surgery alone. Contrast that to a 30 to 45% mortality within 5 years from lung cancer, and you realize that we're just not doing an adequate job of differentiating patients who've been cured by surgery with lung cancer and those who must harbor metastatic disease and unfortunately are destined for recurrence and early death. So there is an unmet need for more precise, better differentiation based on prognosis in early stage lung cancer. And unfortunately, that situation has not changed in recent years, even with the advent of our new staging system. These patients who are dying are often dying with metastatic disease. Now the question is, even if we were able to identify those patients and know which patients truly were not really meeting a quote-unquote early stage designation, is there something we could do to improve the outcome for those patients? All right. I would suggest that there is something we can do. First of all, stage 2 non-small cell lung cancer, on the books, there is a very firm recommendation that these patients, certainly those beyond stage 2A and most of the patients in stage 2A themselves with nodal disease, there is a firm recommendation for adjuvant chemotherapy, and that's based on at least 3 large-scale prospective randomized studies done over the past decade that have indicated a survival benefit to these patients with adjuvant chemotherapy. That survival benefit has been demonstrated in stage 2 disease and also in stage 3A disease. Now, even though there's this very firm recommendation, there are a lot of patients who choose to forgo that intervention early after operation. Why is that? First of all, these patients have undergone a very morbid, often painful operation, even done in a minimally invasive setting. There's certainly a lot of early postoperative issues that they need to deal with. And remember, these are largely elderly patients. The average age of diagnosis in non-small cell lung cancer is about 70 years old. So these patients have comorbidities. They've gotten through a big operation. They're not very enthusiastic about another morbid course of therapy involving a platinum-based doublet. But there's another factor as well. The studies that we have to convince the patients that they will derive a benefit from this morbid therapy, again, have taken all comers, all stage 2 patients, which represents 50 to maybe 65% of patients who do harbor metastatic disease, but the rest of those patients have been cured by their surgery alone. So the absolute benefit to that entire group has been relatively small, in part because when we've studied those patients in these prospective studies, we haven't been able to focus in on the patients who are truly at the highest risk for relapse through undetected metastatic disease. So unfortunately, the statistics we're able to offer these stage 2 patients is that there's about a 5 to 15% absolute increase in survival. And oftentimes that's just not enough to motivate these patients, since they don't know, are they in a very high-risk population or are they among the stage 2 patients who've been cured by surgery? Now, we also know from those studies that as a patient's stage goes up, they go up from stage 2 to 3A, or in these studies from 1B to stage 2, they tend to get an increased degree of benefit of the chemotherapy. Now, stage, remember, is just an indicator of prognosis. The entire staging system is just a prognostic system that's been derived from retrospective data. So when these patients' prognosis gets worse, the degree of benefit that they derive from a treatment that would address that high risk of disease gets better. But again, there's no way to identify stage 2 patients who are at the highest risk of disease. So there's no way to motivate the patients who will derive the most benefit and guide them toward the therapy. Now, it's not just the patients who are hesitant. Very often, we as clinicians are somewhat conflicted. We see a patient with a lot of morbidities, and we're not sure if they really will derive enough benefit from the chemotherapy, not knowing their exact risk, in order to justify the risks associated with that chemotherapy. Well, if we had better differentiation of risk, even within stage 2, and we could identify the patients who are at the highest risk of death within 5 years among stage 2 patients, not only would clinicians know that they really need to target those patients for a likely more effective intervention, but the patients themselves would know that at least the decision they're making is based on a better understanding of their true clinical condition. Now let's turn our attention to stage 1. Okay, there may be a way to use better prognostic information in refining clinical decision making among stage 2 patients, where we know that there's a benefit from adjuvant chemotherapy. The dilemma for stage 1 patients is that the randomized prospective studies that have been done in the past have not yet given us concrete, definitive evidence that there is a survival benefit to these patients from adjuvant chemotherapy. But remember, we're talking about a heterogeneous population, now the majority of which have been cured by surgery. So there's a very high bar to be reached by these prospective studies, which in general have not enrolled very large numbers of stage 1 patients. But there's something else that's very important to remember about our recommendations for these patients. Even the baseline default level of evidence for current NCCN guidelines, if you look in the small print, is level 2A. We'll get to that later on the next slide. In other words, even the NCCN is recognizing that we can't always rely and depend only on prospective randomized data to guide every decision for a daunting clinical challenge like non-small cell lung cancer, where the stakes are so high for so many patients. There are instances in which we have to use the best clinical information we have available to guide the best possible decisions for each patient. So based on that understanding, that underlying conceptual framework for these recommendations, the NCCN has gone ahead and made a level 2B recommendation, which again is a consensus recommendation, even in the absence of prospective randomized data, that high-risk stage 1 patients ought to undergo adjuvant chemotherapy. Why? Because high-risk stage 1 patients face a 50% or perhaps even greater chance of death within 5 years from recurrence of their disease. And that's just too darn high for us to allow these patients to go untreated when we know that adjuvant chemotherapy can increase the chance of survival with patients who have micrometastatic disease. Let's think about that for a moment. From our prospective studies in stage 2 and stage 3A patients, we know that long-term survival is improved with the application of adjuvant chemotherapy after surgery. That means that these patients must have harbored metastatic disease, again, that was undetectable. But their long-term survival implies that level of micrometastatic disease can actually be eradicated by chemotherapy in the adjuvant setting. Now, that's revolutionary, because when we think of chemotherapy in late-stage lung cancer, we very rarely, if ever, think about eradicating the disease or achieving cure. So treating early post-operative, quote-unquote, undetectable or occult metastatic disease may actually be a different entity from treating large macroscopic detectable metastatic disease in the late stage. It means that we actually have an attempt to achieve chemotherapeutic cure for these patients. And that's an enormous opportunity. So the NCCN has taken that knowledge and that understanding, albeit from clinical trials in a slightly different setting, and they've said, well, stage 1 patients also very often harbor occult metastatic disease. And since that metastatic disease is not likely to be any more challenging than the micrometastatic disease of stage 2 patients, who we also think by staging have localized disease, there's no reason to expect that occult disease in stage 1 would be any less amenable to treatment or even eradication than stage 2 or stage 3A patients. And so NCCN has said, find the patients in stage 1 that are at the highest risk and go ahead and treat them with adjuvant chemotherapy. Well, how do you find stage 1 patients at highest risk? If you're only left with conventional means and traditional TNM staging, of course you're going to focus your attention on stage 1B. By definition, stage 1B patients are at a higher risk than stage 1A. But since stage 1B patients have not been found as an entire group to benefit from adjuvant chemotherapy in prospective studies, NCCN goes further and says among stage 1B patients, higher risk than stage 1A, add another group of criteria that we think are associated with poor prognosis. So there are 6 criteria, all but one of which have never actually been associated with a benefit from chemotherapy, but they say use these criteria to find the highest risk stage 1 patients and go ahead and treat them with adjuvant chemotherapy, even though there's no real large-scale validation that those high-risk criteria truly identify the patients at highest risk. All right, we've talked already about the fact that the default level of support for NCCN guidelines for non-small cell lung cancer is level 2A, i.e. no prospective randomized data. There's no question that this is a lower level of evidence, but it still may be the best information we have available to synthesize into a treatment strategy for patients who are facing a very, very challenging clinical situation and a very high risk of death. And rather leave those patients alone with no intervention that could potentially save their lives, we now, every day of our clinical practices, are facing a difficult decision in which we need to take this best available information and make a strategy for each individual patient. Well, there's rarely been an instance in clinical medicine where better information has not led to better decisions and better outcomes. And so here we really see an even more stark need for better differentiation of risk and better prognostic information among these early stage lung cancer patients to guide better decisions, which may actually end up saving some of their lives. Well, if we've convinced ourselves that there's a need for better risk discrimination and better prognostic information in early stage non-small cell lung cancer, how have we done so far in meeting this unmet need? Well, we've learned from breast cancer and other clinical situations that a genetic profiling of tumor tissue can actually add very valid and very reliable and meaningful prognostic information to the clinical assessment of our patients. In fact, in breast cancer, it's become the standard of care to get, for certain populations of early stage patients, a genetic expression profile that then guides therapeutic decisions. So many researchers across the globe have looked over the past decade for a similar type of genetic expression signature in early stage lung cancer that could be used to fill the same unmet clinical need. Now, what I'd like to point out is that although there have been 15 or more of these studies published over the last decade, including one from our own research group 6 or 7 years ago, these studies have depended on frozen tissue that's been dropped into liquid nitrogen in the operating room, and most of these studies have relied on microarray technology in order to develop a gene expression profile. Now, those are very effective tools in the research setting, but they're not very practical for going forward into a clinical application that could be used in widespread clinical practice. It's not very convenient nor realistic to expect surgeons across the country or across the world to begin a practice of snap freezing their patients' tissues. Microarray technology has certainly improved and become refined, but it's still very operator dependent in many respects and not as robust as quantitative PCR. Now, a more daunting problem perhaps for these prior studies is that they've been developed on a medium scale in some instances, but they've never undergone very large scale independent blinded validation. And that includes the Director's Challenge project published in 2008, in which an independent blinded validation was undertaken, but failed to actually validate the best algorithm that was developed from that research in the stage 1 patients in which we've already identified are perhaps at greatest need for better prognostic information. And so in our program at UCSF, we decided to take on this challenge, not just of making a prognostic gene expression signature in early stage non-small cell lung cancer that clinicians could begin to rely on, but we really focused on making it practical, making it a test that can be used for every patient that undergoes surgery. And that requires using not fresh frozen tissue, but paraffin-embedded tissues that have been fixed in formalin. Now, expression profiling generally depends on messenger RNA, and that RNA is very delicate material and very often degraded during this fixation process. But it's possible to derive fragmented RNA from these specimens. And using, again, modern quantitative PCR technology, it's possible to, in a very reliable and reproducible way, derive expression information from that fragmented, so-called lower quality RNA. Now, we chose a very large cohort of patients from UCSF to build this assay, and we decided to depend on quantitative PCR rather than microarray or other technology to develop our gene expression measurements. Then we went through a very rigorous process of statistical analysis in which we actually limited the ability of our algorithm to separate high and low risk patients in our training cohort of UCSF patients so that the algorithm would not be, quote unquote, overfitted to the idiosyncrasies of that training population, but would be more likely to work effectively in identifying high and low risk patients in the real world outside of this UCSF cohort. Then we turned to our colleagues in the realm of lung cancer to help us undertake independent blinded validations on a large scale. And we looked to two sources. We turned to our colleagues across San Francisco Bay in the Kaiser Northern California research program. They have in the past undertaken very important independent validations of other similar studies, and we asked them to look at close to 500 of their early stage lung cancer patients to see if this assay did in fact successfully differentiate high and low risk patients. We also turned across the Pacific Ocean to colleagues of ours in the China Clinical Trials Consortium and asked them on an even larger scale to test this algorithm independently in a blinded fashion among their patients. Now again, the assay itself involves measurement of expression of specific genes from among lung cancer specimens that have already been fixed in formalin and processed into paraffin. So the assay involves getting that RNA out of those paraffin blocks and paraffin sections, and then undertaking a very specific, refined, quantitative, real-time PCR methodology so that we very reliably measure the expression of those genes. Then we apply the algorithm, and what we end up with is a risk score that it gets trifurcated into patients with high risk of recurrence, intermediate risk of recurrence, or low risk of death within 5 years after surgery. And let me refine that. It's not actually a recurrence score, but a risk of death score within 5 years after surgery. Now, those two large-scale blinded international validation studies were brought together in one publication that was released and published in The Lancet in March of 2012. That validation involved a large cadre of our colleagues from around the world and a large representation of institutions, not just in the United States, but in China, where they really have an outstanding level of clinical excellence in the delivery of lung cancer care. And just to tell you a little bit more about this China Clinical Trials Consortium, it was initially built with leading institutions in the major cities along the eastern seaboard of China and has since then expanded out to involve leading clinical centers in other parts of China where the delivery of clinical care is at the highest level of international standards and where this new consortium has brought in the highest level of global research standards to make sure that the data are as believable and as reliable as those from our colleagues in the Kaiser Northern California Department of Research. What about the data? Well, these two graphs really tell an important story. On the left side, you see the survival curves of low, intermediate, and high-risk patients in the China cohort, and that represented patients in stages 1 through 3A. On the right, you see the graph of survival among, again, low, intermediate, and high-risk patients in the Kaiser Northern California cohort. Those patients were all stage 1 patients from their system of hospitals in Northern California. Now, one thing I do want to emphasize is that this assay was developed not for all histologies of non-small cell lung cancer, but specifically for non-squamous non-small cell. Why is that? Squamous cell carcinoma of the lung has clearly been identified to be a different biological entity from the non-squamous varieties that we encounter. How do we know that? Well, there are a number of pieces of evidence. Molecular studies certainly have shown a very difference in biological activity of these tumor cells. But even at the clinical level, we know that there are therapies that will work for adenocarcinoma that just are not as effective in squamous cell carcinoma, and vice versa. So that we know clinically that these are two different entities, and that certainly was borne out in the research laboratory. So rather than try to force these entities into one genetic algorithm that wasn't really well suited for either, we chose to refine this genetic expression profile for patients with a more uniform disease, i.e. non-squamous non-small cell lung cancer. Now you can see the separation of the survival curves in both of these cohorts are very similar. You see, of course, slightly better overall survival for the stage 1 patients in Kaiser compared to the mix of stages 1 through 3A in the China cohort. But the separation and the validation of the algorithm are really quite striking in their similarity between these two populations. To the best of our knowledge, this is one of the first demonstrations that the genetic activity of non-small cell lung cancer is a relatively uniform entity, whether you're taking a population with one genetic background from Northern California or a very different genetic background of patients in China, and applying one genetic test to both of those populations. Now, it's been set up as a challenge to these types of gene expression algorithms that they be able to do better than just classical TNM staging in differentiating high and low risk patients. One of the ways that you test that is by looking within each stage to see whether or not the algorithm separates stage 1, stage 2, and maybe even stage 3 patients with different levels of disease. And this algorithm and this test met this challenge quite well. Of course, in the Kaiser population, we were only dealing with stage 1 patients, but in the China cohort, we had stage 1 and stage 2 patients that we could look at independently, and you can see here that in these two graphs that the genetic expression test truly separated out stage 1 patients at different levels of risk and stage 2 patients at levels of risk. And even though it's not shown in this slide, we saw the same good separation with very, very tiny p-values among stage 3A patients as well. Now, any program like this is going to want to look at multivariate analysis, and sure enough, there was a very profound increase in the hazard ratio associated with a high-risk score from this genetic expression test. And although the print is a little bit small, you can go to the Lancet publication to see more of the details. Even in multivariate analysis, when we were able to look at all the traditional risk factors among stage 1 patients that have been associated with poor prognosis, the hazard ratio for the high-risk test, adjusted for all those factors, remained above 2, indicating a very high correlation of this assay with patient outcome, even among stage 1 patients, even considering the size of the tumor, which up until now is one of our best prognostic indicators. Now, of course, a similar univariate and multivariate analysis was performed in the China population, and we saw very similar results. But this time, because we had a mixed population of stages 1, 2, and 3 patients, we're able to adjust the hazard ratio analysis even for stage. And even adjusting for stage, we see a very significant, very substantial increase in the hazard ratio associated just with a high-risk score from this gene profiling assay. No clinical covariate information introduced. This is all based on a gene expression profile reflecting the molecular biology of the tumor. Now, one other thing I'd like to point out at this juncture is that this looks like pretty good validation data, but you might think, is this really comparable to our validation of staging, which guides most of our clinical decisions, certainly in non-small cell lung cancer? Well, think about it. 500 patients in Kaiser, 1,000 patients in the China Consortium cohort. That's roughly 1,500 patients. Even the new TNM staging system for stage 1 was validated only on about 2,200 stage 1 patients. So we're talking about a similar scale of validation for this molecular prognostic assay compared to the validation even of our new important T&M staging system. So these are data that a clinician can really rely on in terms of inputting more information into difficult clinical decisions. And if we think about a direct comparison of this prognostic assay with the prognostic information that's available from conventional criteria and especially from T&M staging, we can look to statistical methods that have underscored the true improvement in prognostic information that this type of molecular analysis has provided. I particularly want to focus your attention on the graph on the right side of the screen. This is an OROC analysis, which represents the area underneath the receiver operating curve, which is one of the most reliable, most relied upon methods for comparing two prognostic tools. Now remember, these are not diagnostic tools, and therefore there's no way to apply a positive or negative predictive value in comparing the tools. Instead, they're stochastic or probabilistic tools assigning each patient a degree of risk. And so we need to use these slightly more sophisticated statistical tools to compare them directly. Now remember, NCCN Guidelines have told clinicians, look, stage 1 patients are facing a 30 to 45% chance of death, and among those patients are high-risk patients for whom the risk of death is even worse. NCCN has said find those patients and treat them with an adjuvant chemotherapy that might save their lives. Well, if we compare directly those NCCN high-risk criteria that they have suggested in their guidelines to the differentiation of risk that's possible now with this molecular expression profile assay, and that increase in the dark blue area under the receiver operating curve shows a dramatic improvement in prognostication, that means that you're now better able, much better able, and more reliably able to identify high-risk patients among stage 1 better than current NCCN suggested criteria, which means you could carry out that existing recommendation from the NCCN to treat high-risk patients now with much more reliable prognostic information so that you know you're really finding the highest risk stage 1 patients and offering them an intervention that may save their lives. Now finally, I'd just like to focus your attention on some even more recent data that were published late last fall in JAMA, in which we focused on a subpopulation of this large international cohort that not only had stage 1 disease, but had T1A tumors, the very smallest tumors according to our staging system, less than 2 centimeters in diameter, node-negative patients who we believe have the best possible prognosis among resected lung cancer patients, patients whom we would never consider offering adjuvant chemotherapy. But remember, 25% of those patients are going to be dead, most of them from lung cancer within 5 years of surgery. So obviously, conventional criteria and traditional staging are not doing a good enough job of identifying only those patients who've been cured by surgery and separating out ones that are more likely to have metastatic disease. That is exactly where this genetic assay can come into play. We applied the assay to these patients, and we were able to identify high-risk patients for whom the 5-year survival was no better than 50%. So even among these patients with T1A, small tumors whom we believed are cured in the operating room, this genetic assay is able to identify those patients with a 50% mortality, very similar to the stage 2 patients who are now firmly recommended to undergo adjuvant chemotherapy to try to mollify that risk of death. And this was just not a tiny sliver of the overall population of T1A patients. This was a full third of those T1A patients that are found to be at 50% chance of death within 5 years. All right, what have we gone over this morning? I think we've convinced ourselves again that there's a real need for better prognostic information than conventional criteria and T&M staging are able to provide in order to guide more refined clinical strategic decisions for our patients with early stage lung cancer. I hope I've convinced you that we now have available a very robust and very reliable and very practical assay that can be used for just about any patient to do a better job of risk prognostication among stage with non-small cell, again, non-squamous lung cancer. Now, this assay is reliable precisely because it's been independently validated in a blinded fashion in two of the largest international cohorts that have ever been assembled to study the molecular biology of non-small cell lung cancer for any purpose. And we've actually demonstrated through that cohort that this multi-gene assay outperforms conventional risk factors and even the TNM staging system to identify patients at the highest risk of death after surgery for lung cancer. And so what can we conclude? Well, we need to do a better job for these patients because too many of them are dying despite our best attempt at operative cure. We do have evidence that we can actually eradicate metastatic non-small cell lung cancer. How can we do that? By identifying it at its earliest stages in the adjuvant setting when conventional criteria are unable to detect the metastatic disease. We get improved long-term survival and not just palliative prolongation of survival, which is all we tend to see in late-stage disease. Plus, the benefit from that chemotherapy tends to increase and be greatest among the patients who are at highest risk. Therefore, it really behooves us as clinicians to go beyond the limitations of purely prospective randomized study data, which, let's face it, is very limiting to our practice, and to use the best information that's available to us now to identify the patients who, A, need intervention the most, and B, are likely to benefit the most from an intervention. We are already making difficult decisions in the management of these patients and relegating many of these patients to just waiting for their death sentence to be carried out. Isn't there something we can do with this better information to make better informed decisions at a time when we might actually be able to intervene, impact their survival, maybe even save a few lives? Now again, we're talking about changing a paradigm. We're talking about eliminating just a watchful waiting approach for these patients at very high risk of death and instead turning to a new type of tool, a tool that looks specifically at the biology of an individual patient's cancer and using that better, more refined, discriminatory prognostic information to say, well, this patient really is at high risk, we really need to intervene. Whereas other patients, okay, these patients now we know, even beyond TNM staging, are at a low risk of early death after surgery. Maybe those are the patients for whom the monitoring and the watchful waiting is more appropriate. Hopefully this type of paradigm will help us to shift survival in non-small cell lung cancer, something that we've been trying to do now for 30 to 40 years. All of the excitement about targeted therapies, EGFR therapies, and the like have helped us prolong survival in stage 4, but let's face it, very rarely have we cured a patient with advanced, either locally advanced or systemically advanced disease, even with a targeted therapy. Those patients still die. We have a chance to save more of our early stage patients by introducing a personalization of risk discrimination in early stage management that might actually increase their survival. Now, we at UCSF and many of our colleagues across the globe are already engaged in a longer-term prospective randomized study that will specifically attack this question of how much can we improve the survival of high-risk stage 1 patients by applying adjuvant chemotherapy specifically in that subpopulation of patients whom we can now identify to be at highest risk. But remember, that type of prospective randomized study is not going to get done overnight. We're launching that study now, and we hope to have the data available in our lifetimes and in the lifetimes of some of our patients. But can we really just sit around and wait for those most pristine data to be available and ignore new data that may already be available to help guide decisions in the here and now? Finally, I wouldn't be doing justice if I didn't more definitively acknowledge the enormous contributions of many brilliant and talented individuals to the development of this technology. My close friend and colleague David Jablons, who is the leader of the thoracic oncology program and the builder of the thoracic oncology program at UCSF, worked with me closely to spearhead all of these studies. We benefited immensely from the contribution of Dr. Johannes Kratz, who's now back out in Boston at Massachusetts General Hospital, and a wealth of other individuals, again from across the globe, who really were indispensable to the successful completion of the research that I was able to share with you this morning. Now, I understand that some of you may have, through the internet, sent some questions that I can try to address, and I'm going to ask one of my colleagues here in the studio to see if he can provide those questions to me so that we can have more of an interactive discussion this morning. I also understand that there may be a chat room available to us immediately after this talk is finished if there's additional questions that you might have which you'd like to address in a written format.
Okay, thank you, Dr. Mann, for a great discussion. We've got one question coming in, which is, first, how can I use the information from the Prognostic assay to guide treatment decisions if there is no prospective randomized data indicating a benefit of chemotherapy in stage 1 patients?
Okay, thank you very much. Again, not an uncommon question. People in the world of oncology are used to having very evidence-based means for guiding their decision their decision trees, especially when the treatment involves a chemotherapy that by nature is very morbid and may even have mortality associated with that intervention itself. And we tend to think in limited terms, how could I possibly relegate my patient to a very morbid therapy without very definitive, prospectively randomized data to guide that intervention? Well, as I've tried to address through the talk, we're making that difficult decision whether we want to or not. We are looking at patients who have a 50% or greater chance of death from a disease that we know does have an effective treatment. What's limited are our tools to identify those patients. Now we have better tools to provide better prognostic information. In just about every aspect of medicine, and oncology is no exception, we are never really dealing with every individual patient a context that has been documented in a prospective randomized study. Prospective randomized studies always have very rigid inclusion and exclusion criteria to guide us toward a very specific patient population. Very often, the patient in our office does not meet all of those criteria. But what we do is we extrapolate the best possible information from what's available applied to this patient's individual clinical scenario. Well, albeit we're talking about perhaps a larger scale of patients now when we're thinking about all of stage 1, but there's a very high percentage of those stage 1 patients that we can now identify as being at very high risk of death, even after complete resection of their lung tumors. And is it ethical to withhold a potentially life-saving intervention when we know these patients are at very high risk of death and have a very reasonable chance of benefit from an intervention, even though we haven't yet completed the prospective randomized study targeting specifically those high-risk patients that would give an opportunity for definitive prospective randomized data? We're undertaking that study, but in the interim, is it really ethical to leave those patients without any intervention when there isn't a known intervention that has a very reasonable supportive body of evidence that these patients are likely to benefit? And when we talk about benefit, we're talking about potentially saving their lives.
Thank you. The next question comes in, and it's around what is the significance of the intermediate risk score?
Very good question. We chose to trifurcate the risk scores when we developed this assay and its clinical application, rather than just high and low risk patients, to look at high, intermediate, and low risk patients. We realize that clinicians really need to know who among their early stage patients, who among those stage 1 patients, who among those stage 2 patients are really the patients at highest risk of death. Because those are the patients where the difficult decisions become less difficult. If we could identify the patients who are really facing a very poor prognosis, a very high chance of 5-year mortality, those are patients that are much more likely to benefit and in very severe need of that prognostic information in order to make a truly informed decision. So we chose to trifurcate the data so that we had a lot higher level of confidence that patients whom we're identifying as high risk of death are really different patients from those who we're calling low risk of death. And that intermediate group gives us that buffer to have an even higher degree of confidence that high-risk patients are truly highest risk and low-risk patients truly have the lowest risk of those that we can identify with this assay. Now, the intermediate patients are patients too, and they need help, and they need to make their own decisions. We certainly have no less information than we did before running the assay. And perhaps now we have a little bit of more information to guide those decisions as well, because we know those patients are not in the highest risk group. Granted, they're not in the lowest risk group either, but that is meaningful information that we didn't have before, and that information needs to be funneled into the most informed decision possible for all of those patients.
I think a follow-up to that is does the assay incorporate any clinical covariance or other clinical data in its determination of risk?
So as I mentioned briefly in discussing the data from our publications, the algorithm and the risk score generated by this test depend entirely on the genetic expression data that we derive from the patient's tumor tissue itself. So we are not incorporating any clinical covariates into that decision making. One benefit of that approach is that it's truly complementary information to traditional risk assessment and conventional T&M staging. We're not introducing any of that information into the assignment of risk based on the molecular profile. It also eliminates any confounding of that information in the determination of risk that's truly based on the biology of the tumor itself. Because we think the benefit of this test is that it is introducing a biological approach to understanding the tumor that will give us the best handle on knowing whether that tumor is likely to have spread or whether that tumor is perhaps more likely to have been cured by a presumably complete resection in the operating room. Now, something else that I'd like to emphasize here is that these data really can be used to add additional information to all of that clinical covariate information that we already have. And yet we believe that it's based on the natural course of the tumor's evolution from its earliest phases of perhaps pre-invasiveness or micro-invasiveness to full-blown metastasis and late-stage disease. That's in contrast to other types of genetic-based information of which we now have an abundance in lung cancer, where we're looking primarily at genetic mutations that may have predisposed the tissue and predisposed the patient to developing a lung cancer. The most obvious examples, of course, are EGFR mutation and ALK translocation. In those instances, there's a genetic background within the cells, whether it's acquired or inherited, that we believe has predisposed those cells to enter a pathway toward malignancy. And those tumors, therefore, may have an inherent susceptibility to various types of interventions, and maybe even have a natural history that's somewhat divergent from tumors that don't have those specific mutations. But we're not focused on mutations in this particular assay. This is a gene expression profile, which means it's looking really at the behavior of the tumor, not at its genetic origins. And it's going across the board. It's not focused on a specific subtype of tumors that have perhaps been derived from specific genetic mutations. It's really looking at the biology of the tumor and quite likely at the biology of the patient's response to the tumor. The genes that we've chosen to compose this assay were not picked just by rational design. We actually let the statistics guide our selection of these genes. We started with about 200 genes that were known to be involved in cancer and in lung cancer specifically. And through preliminary studies, we honed that down first to about 60 genes, which we studied more intensely, and then finally a set of 11 genes that the outcomes of the patients told us were associated with more prognostic information. And we let the tumor tissues guide the selection of those genes, not what we believe to be our knowledge about lung cancer based on first principles. So some of these genes are related to the EGFR pathway. Some of these genes are related to developmental signaling pathways such as the Wnt pathway, which is almost certainly playing a large role in the evolution of these cancers. But some of these genes are related to metabolism, and some of these genes are even more related to the immune response within the tissues to the tumor. And so we're really getting a landscape or a cross-section of the tumor biology and the patient's biological response to the tumor that's helping us to understand where in the evolution of this individual patient's disease did this tumor sit when it was resected from the lung. So based on all of that information about the biology of the tumor, independent of clinical covariance, we're able to say, okay, this tumor seems to be here on its progression towards almost inevitable metastasis had it been left alone. Is it more or less likely to have already spread outside of the confines of the lung and outside of the confines of the resection specimen? And does that patient, therefore, likely stand to benefit from further intervention?
And I think we have one final question coming in. This person is interested in the biochemical correlation in cancers in general and specifics. In early stage, are there such prognostic correlations?
Very important. What we've learned over the past decade or two is that there is definitely a correlation between the molecular biology of the tumor at any given point in time and the overall prognosis for that tumor in terms of its likelihood of being associated with metastatic disease and a poor outcome. I mentioned earlier the experience in the realm of breast cancer where very similar expression profile testing was introduced nearly a decade ago and has become the standard of care for at least certain early stage breast cancer patients who are often being told that they're at a very low risk of recurrence and often are told they can safely forgo adjuvant chemotherapy. So we have examples from a number of different tumor types in which we've documented fairly well on a large scale now that the molecular activity of the tumor is very closely related with the outcome for the patient, and that almost certainly is connected through a better understanding of the evolution of that individual tumor along this progression toward eventual metastatic disease. Can we make a lot of assumptions about the molecular biology of tumors based on less well-developed early studies? No, of course not. We need to rely on large-scale validation to understand the true correlations between discoveries in the molecular realm and what's going on, especially with early-stage patients whom we hope have a better outcome down the road. But one thing we know is that we need to do better than just looking at traditional 17th century technology in order to understand the prognosis for these patients, because they're facing real challenges and there are interventions that we have to consider in order to improve their likelihood of survival.
Okay. That looks like I don't see any more questions. Thank you, Dr. Mann, for answering those so thoroughly. I don't see any additional questions. Perhaps maybe in the chat room, if someone has questions, they may ask there.
Great. Well, I'd like to thank everybody for their attention. I hope this was somewhat informative. Again, we can refer you to the Lancet and JAMA publications. We have additional publications coming down the line, and we hope to intrigue you even further in a number of years with data from our prospective randomized study. Again, thank you very much.